Hello, and welcome to this recorded case. And we are happy to have Professor Lino from Portugal with us. And thank you for coming to our lab.
Thank you, it's a pleasure.
So now I think we are going to have an exciting case today, where we are going to show a young patient who had a failed bypass, and now see how we can do better. Can you show the history slides, please? So here we have a 53-year-old male. And he's not a diabetic, he's only a hypertensive. And in March 2014, which revealed severe calcific triple vessel disease. And he was advised bypass surgery at the time. And he underwent bypass with Lima Y graft, the Lima and graft to LAD and diagonal sequentially, and Rima graft to the OM, the last OM, and vein graft SPG to PDA and the ramus. So he had a complete revascularization, and he was doing very well, and he was reportedly clinically normal, doing well, and his LV function was normal even before and after the surgery. He was exercising very well until recently. About 2 weeks back, he had while he was cycling, he had an episode of angina, and he came back to us. And when we evaluated, her troponin T was positive, and hence we had to proceed with a CT coronary angiogram, which revealed the Lima segment beyond the Rima anastomosis was occluded. So the Lima to LAD and diagonal was completely occluded, and the OM graft was patent. The Rima was flowing well to the OM, as well as the vein grafts to both the ramus and the PDA were functioning very well. So essentially all the grafts except the LAD diagonal grafts were functioning. And the next slide. So the native vessel showed severe diffuse long disease of the LAD, mildly calcific, and the distal left main disease, left main was diffusely disease. We'll show you the angiogram, and the ramus was a patent graft, and OM and the PDA had a patent vein grafts. Here we can see the left main having diffuse disease, and circumflex is sort of co-dominant, large, and we could see that the OM, the circumflex is large and appears to be normal, and the left main appears to be diseased. That's the LAD, which looks diffusely long diseased. So we can see the LAD is diffusely diseased up to the distal segment. And now that today we have to work on the LAD and the left main. It's a long disease, so we have various options in a young patient. And Professor Lino has got a huge experience. He's been a great operator, and I just came to know that he also does a huge amount of TAVI, and also does a lot of coronaries, particular interest in rotablation, and he has a PhD in OCT. So we are fortunate to have you here today.
Thank you very much.
So how do you think?
It's a very challenging case. We have a diffuse disease in LAD in a young patient. I think it's not the case for rotablation. I use today rotablation only for crossing balloons and not for debulking. I think it's an excellent case for a BVS scaffolding. However, we should prepare very well this lesion. The scaffolds are not so easy to implant as the DES, and we should prepare for a good apposition of the scaffoldings. We can see the landing zone for initiate the implant, and the landing zone for put the last BVS in the proximal LAD. The other issue is the left main. We are not sure about the significance of this lesion. Perhaps it is not so significant as we can see by angio. So perhaps I think that we can by OCT check the minimal lumen area of the left main, and after decided to put a DS. I'm a little concerned about BVS on the left main. I think it's not the best option. This is a young patient, and I think it's more the circ is, as you told before, is codominant, and we should have a good final result on the osteon of the circ. And sometimes BVS with this very big struts are not so easy to cross, so I prefer DES in this case for the left main if we should have a PCI of the left main. So my strategy is first OCT, check the lesion, check the OCT, and decide it after.
I fully agree with your views, and I think it's an excellent case for absorbs, but particularly because he's very young, and we don't want to have a long jailed segment with metal stent, and even if you have to put in a metal stent for the left main, it's going to be a short stent, and we don't worry much in case he need to be off antiplatelets later on in his life. It should be a good option, and in case he has to go for a redo, a CABG, it would be a good option to have absorbs in the long LAD. So it's a very reasonably a good option to have a hybrid strategy. As we understand, if we have to treat the left main, the option of DES would be the best because the left main is bigger, and as was pointed out, I fully agree that we don't have much data of absorbs in the left main. So I think left main we can use a DES and plan a hybrid strategy with absorbs in the mid and the distal LAD. So again, we're doing a OCT, although we have a lot of data of IVUS with the left main, particularly for to decide about indication for treating based on the MLAs, IVUS has got a lot of data. I fully agree. We were just discussing, and I fully agree that OCT, if the MLA is more than 6, we can probably safely leave the left main and treat only the LAD. And the only problem with OCT is treating the osteal lesion and left main osteal lesions. But I think he doesn't have osteal lesion, the body and the mid body and the bifurcation, for which OCT is really a good tool for assessing the left main and particularly for assessing BVS. We are going through the right radial approach. We have taken a 7 French guiding. So our plan is to wire both the LAD and the circumflex and do a OCT for initially and assess the LAD and the left main, and then decide after that. Okay. So we always give nitroglycerin before a OCT or a IVUS examination. We are in the LAD now. Cranial.
Yeah, don't you agree? This is.
Yeah, that's fine.
It's a little hard. Okay. It's okay now. Have all this flashing done.
So it's connect the it's connected to the connect. Yes.
Connect.
And
now it's okay.
It's okay.
Sometimes it's a little difficult to put because we can damage the length. We have here. This is the
LED wire.
The LED wire.
The other issue is maybe we probably have to do 2 runs, or because we have a long
one
length.
Is enough.
One hopefully enough. Yes, should we cover that?
The medial LED is for sure very important.
Very
can
tight.
you push a little more?
Yeah, no,
it's not possible.
It's not possible.
Perhaps sometimes it's not the lesion.
Yeah.
Is the wider bias of the catheter, I think. Okay.
The other thing is when we have a occluded LED like this, and when we inject it, sometimes we get into a VT or a VF. So do you suggest that that the contrast staying back?
No, it's
not a major issue. Okay.
Now
it's occluding the vessel.
It's occluded.
So we start from probably.
More, no? Okay.
Yeah, we can go there. Yeah, yeah. Six.
Yeah.
14.
14.
Negative.
Negative.
We will do a sequential dilatation from there and then do distal later.
Yes,
maybe 14, 12,
12,
8, 10,
8, 10,
12,
12,
14.
14,
Negative. Go up here again.
8,
12,
12,
okay.
14.
14, sir.
Yeah.
Okay, now it's okay.
Okay, store panika.
Negative, sir.
Negative. Now we'll come to cord.
I only dilate the proximal, not the left main with this.
Yeah, agreed. Yeah, 12.
I am on 12.
Negative.
Negative, sir.
That's fine. Give me a small test.
Yes,
Test, small test. Okay, that's fine.
Okay,
Go up there.
Good, very good.
Store panninga mele. So we go up here 8.
Yeah.
Don't you want to go
10.
more?
I am on
Oh,
10, sir.
it's slipped.
that's
Negative.
Slipping
Yeah.
LED.
Agreed. Yeah,
You-
8.
If you dissect, it's
I'm
it's
on
it's
10.
great. Okay,
Negative.
it's going.
It's slipping off.
It's slipping.
Go up.
Go, 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 go.
8.
Go, go, go,
I am
go,
on
go,
8,
go.
sir.
Yeah,
Okay,
10.
okay.
10, sir.
12.
12, sir.
14.
14, sir.
16.
16.
Yes, more.
18. 20.
18.
20.
More.
I am
Yes,
on
good, good.
20?
Good, good.
20, sir. I am
Yeah,
on
good.
Good,
Store
very
this.
good. Okay, very good.
Negative.
10. Negative, sir.
Yeah.
I am on 10.
Perhaps you should go a little more distally, no?
Yes.
Why we don't have an OCT now undecided?
In the left main. Maybe IVUS if you want.
Okay.
Huh?
Let's
Okay.
do an
Yeah.
IVUS.
I think we can go up to this. That's it.
Yeah.
Yeah.
Yes.
Imaging started. Pull back. Yeah. Look. 2.2 value vessel. The IVUS is definitely scoring over OCT in this situation, mainly because to avoid forcible contrast injection, because there was a flap which we saw.
The artery is bigger than we thought by angio, for
Absolutely.
sure. Is 3.0 or 2.75. We have a plaque, a big dissection there. Calcium. Can you see the
Fluoro, yeah. Can you show the fluoro also on the side?
Okay.
So we are in the mid, almost up
we're
to-
in the
yeah.
middle.
Yeah, we're just moving to the
Yes,
proximal
yeah.
nearly now.
No,
Yeah.
we are in where where we have the tight lesion. Now we have a dissection.
Yeah. Can you show the IVUS in full screen now? Yeah.
Yes.
Yeah.
Good.
Yeah.
A big dissection. This is very good for BVS implantation.
Yeah.
And this is a big artery.
Yeah. Maybe here it looks like around 3 millimeters. So
And this is good for the patient.
yeah. Some
This is
calcium, so much of
As well,
calcium.
a lot of calcium. A
Yeah,
ring
yeah, almost
more
like
than 180 degrees.
Yeah.
Where we are now, yes, we are in the now we have a negative remodeling of the vessel, and now we have a big vessel. We are in the proximal LED. Perhaps we have an hematoma, and we have a 3.5. Now we are in the proximal LED with a big plaque of calcium. We still have a very hard plaque burden
The company a little
in the proximal LED. So I think we should go with a 3.0 or
go up.
Yes, sir.
6, 8.
I am on 8, sir.
Wait. 10. I think we have got a good balloon opening, so I'm happy with this. Negative 3 millimeter balloon is fine.
here.
Yeah,
Okay.
It's only
A little bit more proximal, a little more here.
Give me a
Okay.
test,
Okay,
please.
I think it's okay.
Yeah.
Okay.
14.
This is good.
Negative. This is a 2.5 28 millimeter absorbed scaffold, which we are going to place in the distalmost LED. We were thinking that to keep the patient with as minimal metal stent as possible would be better for him in the long run, since he's a very young patient. Yeah, the guiding is good. Yeah, that's fine. Absolutely fine.
I think it's fine.
We are beyond the branch. 1. So we deploy the BVS very slowly. So
Yeah.
1. Timer on, please. Yeah. 2.
2.
So we deploy it at nominal, and then we will decide about post-dilatation.
Another 2.5 28.
We don't have a 2.5 28, so we'll put a 23.
We put a 23.
Then we will put a
You put a 3
328.
here. Yeah.
Okay. Now we go double mag. 2.
It will be very nice to have the final OCT
two.
of this case to see if we did
Timer
well.
on. Timer on. So it goes very well.
Good, very good.
Very well.
Slowly.
Slowly.
Sir.
4, 6, 6, 8.
Enough?
Wait. 10.
10.
Single mag. 10,
10.
12,
12, sir.
14.
14.
I think I'm happy with 14. Do you want
Yes,
to go
14
up?
is okay.
Yeah, go. Show this negative. So
10, sir.
12,
12.
14.
14, sir.
Negative. This is the overlapped area, so we go up 14. Can you see the 2 markers? So I think we are exactly at the overlapped area.
8, sir.
12,
12, sir.
14,
14, sir.
16.
16, sir.
18.
18, sir.
Maybe they put the graph there. Can you see a small waist in the middle of the balloon?
Where the balloon? Yeah. Where is the suture of the lima?
Possible, because we are having a small waist there. 12,
I am on 12,
14,
14,
16,
16,
18,
18,
20,
22,
20. Now we go negative. So we were taking the third scaffold. We are okay.
It's okay.
Go up 2.
2, sir.
Store பண்ணிருமா இல்ல
This is left main. This is
negative. Go up 12, 14, 16, 18, 20.
very good.
Negative. One point is when you want to do the overlapping zone, you can't go very high pressures, because if you go 20 atmospheres, we have a 3 millimeter balloon, and you have a 2.5 scaffold down, you can disrupt the distal scaffold. We exceed 3 millimeters. So to be safer side, I didn't go very high with the 2.5 millimeter scaffold, since the 3 millimeter balloon. Negative.
Okay.
It looks not.
Good.
Yeah, it's slightly out. But
It's
yeah,
perfect.
test.
Didn't get ready.
Perhaps
Yeah,
you can
yeah,
go
yeah,
a
yeah,
little
yeah,
proximal.
yeah. I
okay,
think
it's
looks
okay.
okay. I think a little bit
Looks very
overlap.
nice.
I
It
think
looks
we're
very
okay.
nice.
8.
8, sir.
Store and show
The
me.
final result is very good. No?
So the
The
circostium looks good.
Circuit's good.
So do you think we need to do a kissing balloon or not? Not required.
I did now I did an OCT
Yeah.
at the end,
Yeah.
and to see if the ostium of the circ is okay, I
Yeah.
didn't do a kissing balloon.
Okay.
And if all the malposition and the deposition of the BVS are
Yeah.
okay, I leave it
Okay.
and finish.
Okay. So now we have a 4.5 short balloon, which to do a proximal optimization of the left main, and then we take a picture.
4, sir. 13
Well,
more?
16.
16.
Yes,
Yeah, I am on
Okay.
16.
Yeah,
Okay.
that's good.
that's good.
Yeah.
Looks very good.
Yeah. Yeah. Huh?
Good.
Slowly,
very
slowly.
good.
We will do it up later.
Nitro? No. Great result. Very good. I think this is the point where we have this waste in the angel.
Okay.
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 You can see here.
Yeah. Yeah. So so is there a scaffold there into the lumen? Yeah, the scaffold. There's probably a small calcified block,
Yes,
or the
yes.
anastomotic side, the
I
wire.
think this is an anastomotic.
Ah, that's very
You can
good.
see here.
Yes, we can see it nicely. So
Yes,
I don't know whether it
I
will
don't
give
know
way.
if you can
To
gain
break it.
We can break
We
it.
may not be able to break
And
it.
you can destroy the
Yes,
scaffold.
yes.
Perhaps
The OCT clearly shows the circostium is not pinched, and but it looks very
One
good.
more,
So
one.
we are very
One,
happy
one
with the
more.
result.
This is a very interesting case for me is the first case that I see an overlap of DES and BVS, and I think for me it's very interesting. I never did before, and the imaging is very beautiful, and the final OCT is very important to pulse-dilate the BVS in a zone perhaps related with the previous CABG, and the OCT is very important to check the osteon of the circ to decide for a strategy of pulse dilatation with a kissing balloon, and I think it is not necessary to do it with this very free osteon of the circ. Do you agree?
Yeah.
So we are going to pulse dilate the BVS
Yes.
and
Yes.
leave the patient with a very great result.
Yes, and I think OCT has really helped in this case
Zone.
of, it's probably about 8 millimeters beyond the overlap zone. Play that. Can you play that now? Yeah, so we are exactly seeing what is in the angiogram, the same thing. Play.
Yeah.
So
it's
see,
the same.
we can see the angiogram negative. Yeah.
I'm on 12, sir.
14,
14, sir.
16,
16, sir.
18.
18.
So it's around there's no waste in the balloon at all, very surprisingly.
Well, much
It's
better now.
much better. Okay, good.
Good. Okay.
Well,
Great.
thank you very much for this for coming here. It was very nice to work with you. So
No, it was a pleasure to be here. I learned very much about OCT and about this very challenging case. As I told before, is my first case that I see an overlap of a DES of a BVS. In this case, I think it was a good option to not to put a BVS on the left main. It was not a good option, and the angio and the OCT final result are great. And congratulations.